Welcome to the Digital Podcast that explores how different organizations transform the way they create and capture value with digital technology. Mark, it's a pleasure to have you on the podcast. Really appreciate you taking the time off to come and talk to us about all things healthcare and digital. So it's really exciting to have you. Maybe you could start by introducing yourself and your career so far, your experience with working with different technologies and different companies, I should say, both in the public and in the private sector. Perhaps if you can introduce yourself, then we can kick off.
Yeah, a little gallop through my long and varied career. Well, way back when, I studied and graduated to be an engineer. I had a passion about fixing things and problem solving, and went through engineering in heavy industry, manufacturing, service industries, ended up in aviation. And then I was asked to switch to healthcare because of my passion and skill, I guess, in improving processes, businesses, transformation in general, and getting to the nub of problems. And that led me to join GE Healthcare, where I built up the consultancy practice. And we essentially spent most of our time across Europe and the Middle East helping healthcare organizations, mainly provider organizations, from improving the way they deliver healthcare. And then, of course, during that time, the advent of technology, data, the explosion in what you can access and what you can do with data meant that transformation in healthcare really became more and more data and intelligence driven. And then the possibilities opened up hugely. And then I moved to another great health company called Philips and spent time leading the last 3 years actually leading their global healthcare transformation services organization. So I guess in a nutshell, where my passion lies and where I get most energy from is working directly with customers and patients and hospitals and health systems, because that's where the action, I always say that's where the rubber hits the road. That's where the action happens. So hopefully we get a chance to talk more about that as we go through.
Yeah, definitely. And we'll place a lot of emphasis on patient-facing technologies as well, as you mentioned. So I remember when we first met a while ago, just before COVID, which seems like ages ago, right? And I believe you were still with GE Healthcare, and you were leading the development and implementation of command centers in different hospitals. And I would very much like to get into the specifics of that technology and how it enables a hospital to transform operations. But maybe before we go there, I thought, given the state of things, what's happening in the NHS at the moment, I think we cannot avoid talking about that subject. And it would be a great opening into, understanding what's going on in healthcare. Not just from the NHS point of view, but as you said, also from the private perspective. Mm-hmm. What's happening post Brexit, and what can not just from the point of view of technology, what can technology do, but what other types of changes need to take place in order to really transform how we see healthcare.
Yeah. I mean, it's a big topic, and by that I mean it's a hot topic, but it's also huge. And I think a good place to start is, why is there so much impetus and momentum behind digital transformation in healthcare? And I've given this a lot of thought, and it's really interesting to stand back and observe what's happening, because you've got several sort of forces at play. You've got the fact that the explosion in technology and the ability to do intelligent things with data, and I'm talking artificial intelligence, machine learning, in all industries, is just careering forward at a pace that none of us can keep up with, but everyone sees the promise. So that's one driver. And, you hear people talk about digital Darwinism, the fact that society and technology can move on, but actually the ability for organizations to adopt is just nowhere near that pace. So there's a kind of burning need to try and keep up, and people feel compelled. Healthcare policymakers, payers, private companies feel compelled to keep up with that, constant sort of pace of change. But there's also a burning need. If you look at health systems all around the world, and I've been in, really diverse geographies, diverse health systems, and I've done a lot of discovery work, where you actually go to the Gemba, as we say in lean parlance, you go to the place of truth and you listen, eyes and ears, you interview people, you collect data, and what you learn is that the same top 7, 8, 9 problems are everywhere across the health system. And yes, technology and data can solve a lot of those. But to actually get into, how you activate that change is really challenging. And you see that in the NHS right now. Yes, of course, 90% of leaders would say we need to transform digitally. But by the way, I'm surrounded by fires I've got to put out. I've got staff leaving the industry, partly because of overwork and partly because disillusionment with the system. I've got underfunding. I've got a challenge with broken, fragmented health continuum. My care settings aren't connected digitally or otherwise. People are getting older, they're living longer, they're presenting with more complex needs. And add to that consumerism, the fact that we're all used to, you and I, we're not the young generation, but we, I like to think I'd expect to be able to book a hotel or a flight or a restaurant with one click. If I want a new phone, I can get it tomorrow via Amazon. It's kind of our consumer expectations have gone high, and that has translated to healthcare as well. And underlying that, the government have clearly understood, and the health system's clearly understood, that we don't have the foundational data platform governance sharing capability across all of that to even lay the foundation that enables you to access that promise of what digital healthcare could be in the future. So I think that's driving the change. From the private sector side of things, of course, it's estimated to be a $1 trillion market globally, digital transformation in healthcare. Now, those sorts of numbers, make you sit up and listen if you're a private enterprise. How can I access that addressable market? Where can I add value? And therefore, if you're a healthcare leader these days, you quite often get a lot of attention from people trying to sell you the next best way to digitize your care pathways, or provide patient access or manage medication. And it must be, I feel for them. It must be like snow blindness, trying to figure out, what is snake oil, what is just sort of the next shiny thing, and what is really going to make a difference for my patients and my staff. So I think that's what we're in the midst of. Huge promise, huge potential, a near future where we'll all be receiving precision diagnoses and precision medicine according to our genomes. But the reality of today is it's very difficult for individual organizations or health systems to adopt, activate, implement, embed the change quick enough. And we can talk more about that as we go as to how some organizations are addressing that,
Thanks for that, Mark, and we're certainly going to get into that more deeply. Absolutely. Just to bring in a personal experience into what you just described. I'm teaching a course to healthcare leaders, and this includes both clinicians and nurses and admins and other technology enthusiasts, even some people that want to build their own startups in healthcare. And it's interesting how when you mention things like whole genome sequencing, artificial intelligence, personal devices, and the quantified self, and so on and so forth, they all go like with big question marks in their head, and you're wondering whether you're coming from outer space or this is science fiction. And it's exactly the point that you raised. I mean, unless someone is in the private sector and experiencing all those possibilities, right? They're probably stuck in an NHS hospital where they're still struggling with paper-based records, non-interoperability between systems. A lot of them don't even know what the cloud is, whether they can, they don't understand how data can go into the cloud and be shared with other healthcare organizations and analyze the data and do prediction and also all of those things, right? And it's interesting, as you said. I mean, there's so many underlying problems with not just the IT infrastructure, but also some of the governance practices that you mentioned, and of course, the lack of staff, lack of resources that are really challenging digital transformation in the healthcare space, at least in the public sector, right? And their
Yeah,
worlds apart. It's
yeah,
interesting. What you mentioned makes a lot of sense.
yeah. And I think it really comes back to what we perceive as value depends on where we're sitting. So if you're a pharma research company trying to release the next vaccine or the next cure for Alzheimer's or whatever it might be, then your value to you is how can I access huge amounts of precision, patient-centric data relating to the subject area that I'm wanting to run clinical trials on or to investigate further. So your ability to access that is really important. If you're in a medical technology company like Philips or GE, then what you're really interested in is how can I design the best products that have and are integrated value propositions, we call them. It's got to be more than a product. It needs to be the software,
Yeah.
the service, the delivery model, etc. How can I access knowledge about my customers so that I can differentiate myself? That's valuable to me. Is there data I can collect from my installed base, from my machines that are out in the field, from my current customers, from other systems, from OEM agnostic sort of data collection? If you're a patient, I want to know about my health data. That's valuable to me. How long am I going to live? How can I help myself live
Yeah.
longer? And if you're a patient in the process, quite often what you want to know is what's happening to me and what's happening next, and when do I get out of this place? So I think it's really it's easy to get distracted by the monetization of data, which
Yeah.
the private sector would be really interested in, of course. But it's much more important, I think, to be focused on and empathic with the recipient of care. And that's why I got so attracted to the idea of the front line, what really happens on the ground, in the field, with patients during their journey between care settings, because that's where I feel we're underserving
Yeah.
the population, really, in all the investment.
Yeah, yeah, and maybe this is the right time to get into the command center, because I mean, obviously, it takes a lot of organizational effort, and you mentioned the different stakeholders, right? It's the clinician, it's the admin people, it's the patient. There's different stakeholders involved. Everyone wants something.
Yeah,
Everyone perceives value very differently. And I guess this is the whole idea behind the command center, that its ability to look at the whole hospital, right, and modularize and differentiate different activities, and then get insights from that. So maybe you can talk a little bit about how that idea came about, the technology, and then maybe mention a few examples of how you applied it and the results you were able to achieve.
yeah. So just to start with, what is a command center? I think we're all familiar with the images we see of Apollo 13, and you see the Houston uh, mission control is a command center. We see it for air traffic control. These are familiar to most people. The idea of a space in which you've got co-located decision makers. They've got screens in front of them where they're seeing information that's real time, and they're taking action together. So, I can lean over and nudge the guy next to me or the lady next to me and say, we're going off course. What do we need to do to mitigate, correct, eliminate that problem, or to keep things on track? So the command center in healthcare really was born out of the fact that hospitals, and hospitals in particular, were the origination of it, because they're big, busy, dynamic, complex organisms. I think of it as an organism because there's blood flowing through the veins in the form of people, and they're self-determining. The way you move through your healthcare episode should be, a very orchestrated care pathway, but actually it doesn't work like that in the true sense, because things happen, people make decisions, people are variable. So there's a lot of variation in healthcare. So when you look at those organisms, and just the challenge with what I used to describe as crowd control, how do you, there's a lot of focus on how you make a good experience and a good outcome for one patient, but you've not got one patient. A busy ED could see 350, 500 patients a day. How do you manage the crowd to optimize for everyone? And that led us to look at, well, born out of many years of lean transformation in hospitals, is that there's a lot of waste in the value streams for each patient and for all patients. And a lot of that waste is driven by your inability to do the stuff at the top of the value stream. If you've ever done a pure value stream, you'll see all the interactions, the decisions, in a production environment, it would be production control. How do I sequence, prioritize, get resources to the right place? What are the workflows that enable patients to move through that value stream seamlessly? And we realized that that's a very, very difficult thing for healthcare professionals to manage. And, I always smile when I used to go into hospitals and ask, who runs this hospital? And it wouldn't be the CEO. It wouldn't be the chief operating officer. It would be a chief nurse somewhere in something that looked like a broom cupboard with 6 screens, because she had 6 systems she had to deal with. And I'll never forget the quote from one lady who said, "I run this hospital with this," and she held up a pencil. It was actually a Minions pencil, from the film. Minions. Held up a pencil. "I run this hospital with this." I said, "What do you mean?" She said, "Do you know what? This, my intuition, my experience, and whatever data and favors I can borrow and influence I have, is how I keep this place running." And it made me think that actually, if I knew what was going on in her decision process, I'd have some insight into how to help. And so command centers grew up not really because, you see the technology artifact, which is this wonderful space with all these beautiful analytics, but it grew up about understanding what is the problem you're trying to solve right now in this moment. Well, I've got a patient I need to admit. I've got no beds, and this patient can't go anywhere. They've got a particular need for a particular type of bed, a negative pressure bed or whatever. I'd need to move 6 other patients through the hospital to release that bed to admit that patient, but I can't discharge any at the moment because they're medically fit, but there's no packages of care to allow me to step down those patients to a community setting or a social care setting. And by the way, I'm 2 staff down. My numbers are down in ED admissions. We're about to breach, and we might have to cancel a surgery. You think, wow, no wonder it's stressful for healthcare professionals, nurses, and doctors alike. So we got into thinking like, in design, true design thinking terms, is fall in love with the problem, not the answer. Okay, if that's your problem, imagine if you could have information at your fingertips that would help you make a decision quicker. What would that be? What would that look like? And you sort of find yourself in an iterative cycle, which is, well, what I really like is this, and this, and I'd like to know where she is, and I'd like to be able to get hold of him. And why do you need all that? Well, because he can tell me, when he's going to move that patient from that bed to that bed because he runs portering. Okay, so you need portering data, but specifically, what do you need about portering data? Well, when they're going to get around to it, when they're going to get up to. So you see, what you do is you drill down and down and down into what are the 3 or 4 key bits of data that, if was in front of you, would give you real insight into how to make that decision quicker. And we boiled it down to 3 types of knowledge or analytics that would really make a difference. The first was situational awareness. What's going on around me? You need this if you're driving on a motorway. I need to have my eyes and ears to know there's traffic ahead, there's a stop sign coming up, or I've got to get off the motorway. So situational awareness is, do I have capacity? Do I have flow? Is everyone safe? Do I have enough staff, etc.? So that's baseline level sort of operational intelligence, if you like. The next one is decision support. So I have this situation that's come up and I need to make a decision. What are my 3 best options? I can use my gut. One chief operating officer once said to me, I don't need a model and an algorithm to tell me I can't get enough patients out the back door. And I said, no, you don't. But you do need something to help you understand how you improve that situation in the most expedient way. And she went, yeah, you might be right. I said, well, let me show you. Let me start. So there's a sort of augmentation. It's not replacing decision making, it's augmenting decision making. And by the way, this is not clinical decision making. It was never the intent of operational command centers, whether you call them clinical or operational, doesn't matter. It was never the intent to say, administer this drug now, or defer surgery for 2 weeks. It was meant to say, how can you start to be more intelligent in decision making, sequencing, prioritization, access, movement, capacity, flow, etc. And then the third type of intelligent analytic was predictive. So great, you've given me situational awareness, so I can see I'm having a bad day. I can see it's terrible. You're helping me make better decisions in real time, which hopefully will make things better or unblock the blockage. But what's the next 2 hours going to be like? What's coming around the corner? What's it going to be like by the end of the week if we carry on like this? And of course, we'd say, well, why do you need to know that? Do you just really want to make your day bad? No, we then want to know what we can do now to make our day better or a week better. So we got into simulating, creating digital twins of a hospital, not any hospital, your specific hospital. And I might come back to that later, but it has to be tuned to the way you run your hospital. And then you can predict, you can sort of extrapolate forward and say, the way things are going, you're going to be in real trouble by 4 o'clock this afternoon and you won't be able to admit patients. They'd say, yeah, we know that. It's always bad on a Tuesday afternoon. It's like Christmas. It comes around every year and we're not prepared for it, Okay, so if you know that, why aren't you doing anything about it? Well, because we don't know which are the best levers to pull. So prediction has to come with action. It has to be, so that underlies all of this is actionable intelligence. So one of our mantras in command centers was provide only actionable intelligence. If you want something on your screen that is interesting but not useful, that is data that's saying, how have we done for the last 6 months, get it out of there. You can drill into that. You can get your BI team to trend it, whatever. What you want to know right now is only see what drives action. And so we got into the challenges of then designing analytics with, co-creating with the staff. So then they love what they see because it's come from them. And then how do you get the data and integrate it into the workflows so that it gets used? Because ultimately, we all know you can wear an Apple Watch and it can tell you that you should move more or lose weight. But if you don't do anything, you don't change, So the activation, the acting on the intelligence is a key part.
Yeah, yeah. So that's a lot of, I guess, it's quite a complex project, and it's, well, it's a program. It's not a project, right? Because it involves so many different dimensions. And what's fascinating is how you are able to pull together, as you said, data from different sources in real time, because obviously someone needs to collect the data and feed it into the system, right? Otherwise the system doesn't work. It doesn't give you that actionable intelligence.
Yeah.
So maybe say a little bit more about that. You know, how did you mobilize people on the ground to start collecting the, did you give them like iPads, or was it all paper based and then input it into the, how was it done?
So fortunately, you can make huge strides in this by accessing systems that are already there. So every hospital has some form of ADT system or PAS system, admissions, discharges, and transfers. Most hospitals, it's moved forward hugely in the last 5 years, but most hospitals have some form of electronic patient record, some PAC system for imaging, some sort of lab system, some sort of way of ordering pharmacy. So most hospitals have source systems. In fact, the average hospital probably has 300 systems, applications. But, the primary sort of foundational source systems have to be there, actually. Otherwise, you can't admit, discharge, and transfer patients or administer, medication in the right way. So we found that you could make huge strides in a lot of the questions that were being asked in those problem-solving design discovery sessions by listening to data that already exists. And when I say listening to data, I mean there's a very distinct difference between this kind of operational use of real-time data and what a research company, a pharma company, let's say a clinical use of data where you want to collect everything, big data in a data lake, and you want to be able to manipulate heterogeneous data to find patterns, etc. That is laudable. Absolutely, we have to do it. It'll transform healthcare. If you want to make a frontline staff member's job easier and the patient journey easier, you don't need to collect everything. What you do need is the few needles in a haystack that when you put on in one place, and you maybe manipulate them with some relatively straightforward algorithms, sometimes very sophisticated, you can get to the intelligence you need. So what we found was that we weren't implementing a new way of collecting data. We were listening to or ingesting data from source systems. And if sometimes, and it happened, that vital data point didn't exist and it wasn't collected anywhere, then you might put in a sort of web service or some means to collect it. And a good example would be, believe it or not, knowing whether a hospital bed is empty or not. Hospital beds, it's pretty crucial to know if a bed is available. Is a patient in it? Is it occupied? Has the patient left, but the room needs cleaning or the bed needs turning over, so it's available but dirty? Is it available clean and ready for a patient to be admitted? Now, believe it or not, it's quite hard to get that data. Live bed state, as we call it, and some sophisticated methods actually track that with different methods. Pressure sensors on the bed. It might be a switch that's flipped by housekeeping or by the staff nurse. It could be a visual technology or whatever. But some people tried putting tags on patients, and when they discharge the wards, they drop the tag in the drop box. But the interesting human behaviour that happens in a busy hospital when nurses are really under pressure, and they don't want to just have one in, one out every 5 minutes, is they'd maybe just put the tag on top of the box and drop it in the box when they're ready to receive another patient. And it sounds criminal, doesn't it? I mean, not criminal, inverted commas. It sounds like, wow, but that's human nature, is that I've had 50 patients today, and if I get one more today, we're going to break. Just give me 5, So there's challenges to getting really key data in real time, even when you get it from the EHR, because most electronic healthcare records are batch transacted. So there'll be a
Yeah.
bunch of ward clerks will collect the data, sometimes written data, sit in the back room, and by the end of their shift, they might have got all that data into the EHR. So it's not real time.
Yeah.
But I think that's another fundamental success factor to this kind of operational intelligence in healthcare is the access to real time data and the fidelity of that data. You know, the latency of it and the fidelity. You know, is it true? Is it accurate? Is it now, or is it near? Is near real time good enough? Because sometimes it is, but so we had to overcome some of that.
And in comparison to the private sector, would you say that there is more real-time data exactly because of the deployment of these more advanced technology like Internet of Medical Things and sensors and cameras and things like that? Do you see that in the private sector? And is it just because of the technology, or is it also because of the governance structures that are in place, um, the better staffing, and so on and so forth?
Well, so the answer to the first question is yes. You know, if you look at just about every other technical industry, manufacturing, service industries, 20, 25 years ago, they leveraged real time. You know, when I was in aviation back at the end of, let's say, early 2000s, we were remote monitoring aircraft engines on wing to do 3-tier levels of remote diagnostics to advise customers on when to proactively do maintenance or preventative sort of action on that engine to make its life longer.
Mm.
We were modeling risk and analysis of aircraft fleets in real time. Any, I worked in Japan for a while in manufacturing in mid 90s, and they had real time measurement of everything at every stage. We manufactured television screens back before the days of flat screens, and we collected measurement data of every aspect of that entity, the screen, from molten glass through to finished product at every stage to the line. And it was instant quality control, you know, instant knowledge of how the process was varying. So I don't think, actually, I often say you wouldn't build a hospital today, or you shouldn't build a hospital today without having that obviously foundational platform that allows you to share and manipulate and keep data secure and safe, but without being able to track patients and staff and assets in real time, without having you know methods of wayfinding, you know, from engaging with patients once they're in the care setting, and being able to collect that data and use that data. Why wouldn't you? Now, of course, there's 100 reasons why not. Money,
Yeah.
social economics, where in the world, you know, legacy infrastructure.
Yeah.
You know, you go around healthcare facilities all over the UK, and they're struggling at the fact they've got aging facilities and buildings and footprints and infrastructure, and you don't just replace that overnight. You know, so there's a kind of evolution happening there. But I do truly believe if I had the money to build a hospital and I was building it tomorrow, it's foundational to be able to collect real-time data, not everything, but the data you need to be able to manage your operation in real time.
Yeah. And you mentioned also design thinking principles, which I think it's just important to maybe spend a few minutes on that, because um, it is an important methodology in identifying, as you said, the problems and then trying to figure out what the solutions are. But also maybe you could mention how you were able to identify the champions, you know, behind the process, you know, how did you know who to talk to and who to carry out this design thinking with, right? You know, who is who should take part in this, and how do you empower them in this process?
Yeah. So I think, not just in the command center sense, but in large in fact, large transformations in healthcare, you always start by getting a really clear understanding of what is the true strategic priorities. What are you trying to achieve as an organization from the leadership? And that's because depending on who you talk to, they have different views of what success is, and good problem solving practice says, what does success look like for the person who's responsible, accountable for this change. So and getting an idea and helping those teams of leaders really crystallize their vision of where they want to get to. And quite often that vision would be, I want to get to the moon, but at the moment I need a bicycle to get to the launch pad, and we don't have a rocket. So it's a long journey ahead, but that's where we want to get to. So thinking big is important, but you've got to be pragmatic. But then we'd immediately move into discovery mode. So that's where I would tell all of my teams when we went into a hospital is that you don't lead the witness. You don't solve problems at this stage. Resist the temptation to say, wouldn't it be better if, there's technology that will do that. At this stage, you're just empathizing in true design. It's a human-centric activity. You're going to really walk in the shoes of the people that are experiencing the good and the bad of how things operate right now, or how, including patients, by the way, because they're the recipients of this process, or the people experience the process. So we would spend a lot of time, actually I say a lot of time, it's quite intense, short exercise, but a lot of people who have expert eyes and ears to go in and really spend as much time. We could go into a hospital and spend a week and talk to 100 stakeholders, and always going with that stakeholder to the place where they work. Show me how you experience work right now. How do you admit a patient? Oh, it's easy. We do admissions here and it's easy. And then you'd look and it would be 4 screens and 22 clicks to admit one patient, and it takes 20 minutes. Well, okay, now I sense that there's some opportunity here. And then you're already validating that. Do you agree that things could be better? Or do you think that things could be better? Where do you start collecting ideas. And through that process emerges people that really have a passion to make things better. Champions emerge, they always do. And they may not want to be champions, but they might be very vocal about the possibilities. One guy that I worked with, a busy ED nurse in a very high-performing hospital in Manchester, I interviewed him, and I actually took some video clips of this whole thing unfolding during the day, a typical day in the life of the whole hospital. And he said to me, I go home every day thinking to myself, I can't help thinking this could be better. We must be able to do better. And that was off the back of knowing what his day had been like, and the fact that by 10 o'clock in the morning, all plans have gone out the window and they'd had to cancel some significant surgeries because of congestion. So champions emerge, and then you get into we'd say that you open the aperture and then you try and close the aperture. So opening the aperture is the discovery, where everything's listened to. You're sensing the lay of the land and where the priority problem statements are. Then you've got to close the aperture and say, from what we see in our expertise and your data, etc., these are the top 5, 6, 7, 10 priority problems that need to be solved and to be true for you to reach or head towards your vision of where you want to get to. And some of them are quick. Some of them, well, there's no such thing as a quick win, but some of them are what I'd say no regret. Get on with them now. You don't have to wait any longer. You should be working on this now. Some of them could take 3-4 years. So it's never a silver bullet, but it starts to give you a sense of what a program approach would look like. And then we'd get into design mode, so co-creation, ideation, um, with groups of people that coalesce around one of those problem statements. So if the problem is by 10 o'clock every day we're struggling to manage the front door pressure, and we end up admitting more patients because we simply can't deal with congestion, or we can't admit patients and we're having to hold them in ED because there's no downstream bed availability. That's a problem statement. And you say, why is that a problem? Why? And then you coalesce the people there invested in finding a solution around that, and then you start co-creating what process transformation has to change. How can information and technology support that? Because most of the time they're not interested in, believe it or not, frontline workers don't want more tech. What they want is alleviation of their burden so that it releases time for them to care. And technology quite often isn't working for them. I was talking last night to my son's girlfriend, who's a pediatric nurse in our local health board. And I just, I knew I was having this podcast. So I sat her down and talked to her as a frontline worker. And I said, tell me about your experience of digital transformation. And, you could see her face dropping and her head going in her hands, because she still has to go to 6 or 7 different systems. There's never enough equipment, to access a computer. They can't get contact. You have to go to the staff room to log on to the app to order medication, because that's the only place you can get a signal. So that makes you think that unless you're really walking in the shoes of the people that the technology and data affects, then how can you really assess whether you can activate that solution? Yeah, I could talk all day on this sort of thing. I'm really passionate about the last few yards, from a great idea, fantastic technology. Of course, that's what we need, and the reality of activating it. It's a sort of piece of innovation that is often underserved as well, which is,
Yeah.
you have a fantastic innovation, but do you know what? If nobody uses it, or they can't use it, or they can't unlock the value, well, it's going to sit on the shelf, and it's going to be a very expensive thing sitting on the shelf.
Yeah, and I think what you're pointing at, and by the way, thanks for that elaborated description of design thinking. Um, I think you probably have a lot of war stories to tell, but also I would hope that a lot of successes, and I appreciate that the experience must have been quite satisfying and fulfilling for everyone involved. Um, I just want to go back to this point of, I think the point that you're raising is having intuitive solutions into problems, and which leads into this next topic on, you know, the demand from patients. And I think we've seen that a lot during COVID and post-COVID, how people have suddenly realized that, well, wait a minute, I can have care or services and consultation remotely, virtually, through my phone, on demand, when I want it and the way I want it, right? And this it brought in a lot of these new startups with their quite intuitive, I would say, business models, right? Like Babylon Health, Doctor Care Anywhere. In the States, you have Teladoc and others, and in China you have Ping An, good doctor, and so many more, right? And everyone's doing it now, and it's not just the startups; it's also the hospitals, right? I was reading about Cleveland Clinic and how they designed the clinic, right, which is a virtual care clinic. Everyone is doing it because they suddenly realize that, that I think the pandemic has accelerated a lot of transformation, but it has also changed the mindsets, right? It's not just the technology transformation, it's also the mindset, what we can expect to get and what we can get. And if we can get it on our mobile phones, even better. So I want to spend a little bit more time on how the value proposition of healthcare services and the user experience has changed. And when I say user, I don't mean just the patients, but also the professionals, right? Because the professionals are also gaining from this, right? I think there have been some discussions in relation to Babylon Health in the UK as to how it has impacted how even GPs are now perceiving their own individual practices, that they can practice general medicine on demand, not just through a geographical location and therefore be bound to whatever the funds are for that particular location, but rather you can reach out to a different population of patients if you go onto these platforms. So again, going back to the value proposition has changed, the user experience has changed. So maybe you could comment on that, and maybe also mention some of your own experiences on how this has played out in recent years.
Yeah, yeah. I think it's a really fascinating topic area because I was discussing this recently. It's clear to me that, COVID was a forcing function. It was an accelerator of what was already happening, but for reasons probably cultural as much as anything, fear of why would I want to talk to my doctor over a teleconference when I can go and see him and he can prod me and take my measurements. And by the way, that's not real healthcare. That's just a chatbot.
Yeah.
It sort of accelerated that change because fear had to go away. And actually, we were all more comfortable not going near a hospital and not going near a doctor during COVID. So fantastic. That took away barriers that were really standing in the way to progress that was inevitable, I think. And I was musing the other day that, before COVID, I used to do everything on my phone. People would phone me every 5 minutes, or I'd phone someone every 5 minutes. Now my phone never rings. All of business is done now via Teams and WhatsApp and chat rooms and things like that. But and it's quite incredible in such a short space of time how much has changed. And that's really convenient in a lot of senses. And I think there are some really good examples of how, from a citizen, consumer, patient perspective, you feel like you can more quickly get to a point where you feel like you've been listened to, you've got some reassurance, you've got some, again, with wearables and things like that, you've got more of your own intelligence to say, do you know what, I've been tracking my blood sugar or my blood oxygen saturation recently, and I think I've got sleep apnea or whatever it might be. You go in with a proposition to your doctor before you start. And I think, that comes back to the consumerism side, which is we all have more choice and dangerously more knowledge, I think. Where I've seen it start to make it, I mean, I'm not sure about the Babylon type model in healthcare systems, which are more sort of, let's say, Commonwealth like Canada and the UK public health systems, because I'm not sure that level of sort of pervasiveness of access and sharing of information is something that the public is particularly comfortable with at this moment. But it'll come, I'm sure, as long as it serves the right needs and purpose. And
it's true. Babylon Health has been growing much more in the US than in the UK. You're absolutely right.
Yeah. But there are companies that are doing some really interesting thing with, how does that sort of interactive connectivity work for staff? But biggest problem in healthcare, or one of the biggest problems, is the massive pressure on staffing. People leaving the industry, people not joining, the field, and then people being burnt out and under pressure. And so, if you think of something as simple as scheduling staff across not just a single hospital, because that in itself is a challenge, but what about across a care continuum, an IDN or a health system where staff could be more dynamically scheduled
Mm.
to allow them to move to the points of pressure, which is what, again, you do in manufacturing, you do in other industries. You'd say optimize the bottleneck, and where you've got pressure, you put more resource and you relieve that pressure. But in healthcare, that's not the case. And there are companies that are looking at ways to allow the healthcare professional to have more real-time access to interact with their own schedule. So instead of being rostered and saying this is your kind of rota for the next 6 shifts, perhaps you want to choose when is convenient for you. Perhaps you want to choose when you could do more. Maybe you'd like to be able to interact and say, well, I'll do my 3 shifts there, but I can also help in the community hospital because they look like they need help. And giving simple tools to staff to take more empowerment over their own work schedule. Now, it remains to be seen. I think this is working well in Canada, very well, in fact, and I'm waiting to see whether there's similar sort of uptake and opportunity in the UK, because I do feel like there's more we could do on the workforce side of things that would help in so many ways. The experience side of things, I do feel like there's an awful lot of focus on patient experience in the sense of almost like user experience. But when you do true experience flow mapping, find me a patient that says their journey through a healthcare episode has been a smooth, seamless, pleasurable experience. You won't find many, because your points of experience are so diverse and so many that this concept of experience flow mapping, which I learned when I spent time with Philips and the design guys there, is really fascinating to actually understand all of the points of experience and how it affects people through their care journey. And that should then inform how you develop some of these tools and applications to allow not only patient satisfaction, but the patient experience, their preference, their choice will be impacted. They choose maybe to access technology more if it was a pleasurable experience and it was making them feel that they were getting a quality service and outcome.
Yeah, and that's a great point, and it fit into this next topic that I want us to get into, which is the care continuum and the patient journey, right? And again, I understand that you have done a lot of work on this, so this is where all these insights are coming from. And I guess I also want to, again, I want to bring in more of the private sector if we can. But you could just discuss first your work with the care continuum and managing patient journeys. And I believe you also did some work with A&E departments. And
Yeah.
then maybe we can shift into, the expanded care continuum from the hospital to the home, right? How the shift from the hospital to the home and home care is taking place. And again, you can be critical as to whether that is working out or not. But let's start with the care continuum within the hospital. And maybe, you can draw on some of your work with A&E departments in the NHS.
Yeah, and tell me more about what you'd like to explore there.
So you mentioned how it's not a single point of experience, right? So
Yeah.
patient walking into A&E, and then depending on how the patient is assessed, he or she may be hospitalized to be taken for scans, other exams, and so on and so forth. So the whole care continuum, right, is not just a visit and a single consultation with a doctor as in the case of Babylon Health and these other new entrants in the field, which you rightly put it, is it's only the beginning of the journey. It's not the full journey, and therefore it's almost like touching on the surface of the user experience, where there's a lot of other things that happen once the patient enters the hospital and has to be physically examined, has to be physically taken care of.
Yeah, yeah. I mean, it's I've spent a lot of time sitting in ED departments and then following patients through their entire journey through a hospital. And obviously, that's not the only way patients enter a hospital
No,
setting.
yes, absolutely.
But it is one of the most pressurized. And what you realize is that for a long time, there was a lot of focus on ED departments, accident and emergency departments, because it was a bottleneck. And it was the front door, and it was the most prominent. And actually, don't politicians love to talk about ambulances and emergency departments and queues in corridors, because it's a very visible metric. And believe it or not, what we make, the measurements we make important suddenly become the measurements people work on. And actually, quite often the ED department is a symptom. The pressure in an ED department is nearly always a symptom of something else in the hospital that's not working so well. So it's nearly all you can polish, and I've done this for many years. You can polish and polish and polish the processes in an ED department, but it will still be it'll win and lose by the ability to stream patients. So first of all, do we need patients to even attend? And do you have the necessary? That's why you have NHS 111 and services that say, do you really need to come to A&E? Couldn't you see your GP? Couldn't you go online? So you're trying to decongest before that even becomes an issue. And then you start to look into patients do attend. So what drives admittance? So what drives your choice to admit the patient? Well, for a long time, it was because hospitals had to hit. I should be careful saying this is not the only reason, but if you put a target of 4 hours and that you'll be heavily performance managed on a 4-hour target from when a patient attends to when they admit or discharge, then quite often we found from the data that come 3 hours 59 minutes, admission likelihood went up, because you don't want that patient to breach, and you don't quite know where you'd hold them for another hour perhaps to do observations or whatever, but that doesn't look good on your numbers. So so you start to understand that the continuum is driven not only by patient need, but by how the organism works, the system works. And then so often the ability for patients to move out of ED into an inpatient care setting or an assessment unit was dependent on downstream flow, which then stems to what's happening in your perioperative. Sometimes, if it's a busy acute hospital, you might have surgical flow that's interfering with medical flow, or vice versa. But nearly always inpatient beds, not being able to discharge patients effectively. And if you did an on the day sort of day of care audit, as we said, of patients in beds, in many hospitals, around 30% of patients are medically fit to go home or to go somewhere else, but they haven't moved yet. So that speaks to, we're actually pushing hard at the front and we're blocked at the back. So you get intraday congestion, as I spoke about earlier, but everything's interconnected, and that's why I always revert to value stream thinking, because if you're a patient, you're moving through this value stream and the patient doesn't split and go in different directions. If you actually walk in their shoes, you're going, you're stopping, you're going, you're stopping, you're going, you're stopping. And what's stopping you is not because most often it's waiting for a decision to be made, consultation, a movement, a diagnostic. And you see that their continuum of care, the actual individuals, is staccato. It's sort of so start, stop, start, stop, and that's just one patient. When you have 100 flows overlapping, that's where you see the continuum of care becoming a question of priority. if you see how wards manage their flow, they say, is everyone safe? Who's my sickest patients? And have we got flow, and who can we discharge today, just to maintain some level of movement? And
Yeah.
some of the this comes back to simple analytics that make a difference. We started to, in one hospital, well, what if we gave you a discharge target? Well, we know we've got to discharge more patients, but no, what if we said, what's the optimum number that you should try and discharge before 12 o'clock today? And incentivize it somehow. We do ward of the week, actually, for hitting your discharge. And the targets came from modeling, simulation modeling in the hospital, to allow on any particular day flow to continue. And once discharge targets were implemented, it became almost a competitive behavior to say, can we hit our targets? What would it take to hit our targets? Well, we need social care, occupational therapy, physio to all be at our MDT meetings 3 times a day or whatever it be, to help us say, who can we now step down because they're well enough. So that within a hospital, the continuum of care, there's a ton of opportunity with simplicity of you don't need to boil the ocean of data to make a difference, but you
And
do need to put information in the hands of people that can make a difference.
do you think that performance management, giving incentives and providing targets, um, does it help always, or does it sometimes create more tensions between staff and the admin people?
Yeah, I don't think hard incentives help at all. In my not in a public system anyway. But I think soft incentives. We made it fun. Actually, we made it fun. The CEO would come down and shake hands with ward of the week, and they'd get a cake or something. And it would be a fun thing, but also thank you. Because what you're
Yeah.
doing is, here's how it's affecting the rest of the hospital, and therefore affecting the quality of care that we're delivering to our patients. The less they're waiting, the more sort of uh, let's say efficient their care is, makes a big difference to our patients. So if you put it in terms of what really speaks to healthcare professionals is, are we improving the lives of our patients and our staff? But I think another small vignette there on how a simple piece of data can make such a difference. I work with a hospital in central London where they had actually boiled down to one number that everyone needed to know to help manage patient flow throughout the day. And the one number they needed to know was what they call bed balance. And the bed balance was basically the difference between the number of people are waiting to come in and the number of available beds we have for patients. And is that negative or positive? And how negative is it? So if you've got a bed balance of -17 at 10 in the morning, you've got a job to do here. We've all got to get that bed balance up. And the behavior it drove was a sort of collective effort around one number, because that was really a true indicator of, do they have flow? Now, they all figured out in their own ways, through their own sort of experience and the ways and means to do that. But they managed to that number. And it wasn't a reported number to the government. It was the way they found was one of those key indicators that would allow them to steer the ship effectively in the heat of battle. And I think they're gold. They're like solid gold when you find those few pieces of real-time information. It goes back to the lean stuff again. We used to have tap boards and things like that would tell someone you're on track or you're off track. And let's all work to get back on track, because otherwise tomorrow is going to be horrible. And it drives a certain behavior.
Yeah.
Yeah.
Yeah, and I guess also what you mentioned there in the beginning, you said, these remote consultations with a GP can, prevent increased patient flow by screening those patients that actually do not require to come to A&E. I mean, there's a lot of some patients feel that you know, it's better to go and have it checked than wait at home, and that creates a lot of patient inflow into A&Es, right? I mean, there's triage, and you triage people, and you prioritize who has. But still, you know, if you have 100 patients to triage, it takes a lot of time, right?
Mhm. Yeah, so I mean,
So
there's methods that have been employed for some time that's upstream of triage, even where you train up people on reception to be able to screen patients. You know, to be able to say, okay, you don't need to go any further. You know, you can go to our AC ambulatory care department, and they'll take you through a pathway. You don't even describe this. Go through that door there. You know, it's ambulatory care pathway, that because that patient doesn't need to be in ED, but they do need some sort of care and attention. There's rapid assessment and treatment models where you can, or rapid assessment and triage models where you actually someone would come to the waiting room and do a rapid assessment and triage and say, you know, you need a plaster, and then you can go home and take some aspirin or whatever.
yeah,
Um, and then there's ways and means of saying, well, actually, hospital's not the place for you. You know, could we come and see you in your home? So, you know, there's more focus on shifting the balance of care closer to home, which has a lot of promise and a huge amount of desire to do. Because if you think about value based care and the cost per capita of always having patients seen and treated in the most cost centric care setting, which is you know, an expensive teaching hospital or an acute hospital, then there's a lot of good reasons from the quality of care, the experience, and the cost perspective to move care closer to home. But I see challenges in that being realised. I'm yet to see really good emphasis. I mean, the jury's out really, because not on the technology's there through all our discussion today, Panos. I would say technology and data is not the issue. It's the implementation, the application, the adoption, the acceptance. How do you weave it into your workflows so that it's really effective? And how do you take small incremental steps with how that implementation happens? You can take dramatic steps with switching technologies, but the implementation should be piece by piece. But I've seen some really good examples of how remote patient monitoring and care is done. Again, simple. There was a project in the north of England called Health Call, which would allow care homes to, through a tele consultation, say we've got a patient that we believe needs to be referred back to hospital. They gave devices to the care home, so blood oxygen, pulsimeters, you know, blood pressure, a few other sort of simple devices. They do a very simple Muse score, you know, the early warning score, talk with a clinician at the hospital. They'd make the referral there and then, or not make the referral. And through that instant sort of interaction, they were able to better manage the reverse flow of patients stepping up in care back to the hospital. Um, I think the biggest challenge, you know, it's a fairly obvious one, is that uh, the data, the underlying foundational data platforms in different care settings, particularly in the UK, once you go out of healthcare into social care, is so fragmented. So, and also, you know, it does take technology investment to allow you to do remote care monitoring anywhere, in the home or in a care home or hospice or whatever. So there's investment, but there's also, you know, systems aren't talking. You know, the interoperability and the ability to share data is not yet there. But the government um, are investing a huge amount of money in federated data platforms and the ability to foundationally solve. You know, we're going to build a house, but let's get the foundations right, which is you at least need to share data. You need to use common data standards and governance and security, and we need to be able to talk to each other through information for us to do any of this wonderful stuff that's promised by
yeah,
digital transformation.
yeah, and I have also experienced some cases of usually chronic patients. Also, a project that it's in the making in Manchester on mental health and monitoring mental health patients. And again, there you have social workers and community care workers that are involved. But yeah, all the things that you are describing are absolutely spot on in relation to getting the technology to patients is one thing, but then integrating that with um, other infrastructure within the hospital and other settings where you can monitor and do predictions and do all sorts of other things are missing or not robust and scalable enough and secure enough to support such a transformation.
And even if they were, then you've got the challenge that many of the people that are suitable to have that kind of at-home health, depending on age, demographics, social economic environment, their aversion to technology, you could have the technology and the connectivity, and they may not use it or be able to use it or understand it. Or so there's some challenges there, I think, in the actual, like I say, the last few yards of the transformation to unlock the value depends on understanding really not the technology, although that's foundational, but understanding how you activate that potential with a diverse, interesting, from a challenge point of view, cohort of potential users. They're not like necessarily like you and me sat in front of our cameras having a great conversation.
Yeah.
These are often elderly, sick patients at home alone. So yeah, that's another fascinating area to get into in another podcast, probably.
Yeah, yeah, and this idea of ambient technologies and there's technology in the background and these people don't do much with it. I was talking to a colleague in Norway who does a lot of work with digital health, and she was telling me how a lot of these technologies have, they basically work on their own. They don't need the user to do anything, exactly because of the reasons you mentioned. They have to be user friendly, and they have to be able to be turned on and turned off and monitored from a distance, in this
Mm-hmm.
case from the relatives of the patient, as opposed to the patient themselves, because the patients themselves come from a different generation that do not understand all these digital technologies. So I absolutely, and probably a topic for another podcast. Um, but I think, and maybe a last point before we move on. I guess in the private sector and the more affluent user, right? The user who is into health and wellness and fitness and wearing smart devices on their body, O-rings and other such technologies, measuring their own blood glucose, which is quite trendy these days with fitness
Yeah.
fanatics, right? Because they want to achieve their VO2 max and and maximize fat burning and all that. They are driving a lot of transformation. I mean, it's at a different, as I said, they're affluent most often users, but they are driving a lot of these new startups and increasingly the technology is becoming cheaper and more user friendly. And I wonder what your thoughts are on that, and what the impact could that have on healthcare.
Yeah, I'm extremely excited by that, the device side of things, the wearables in particular, because I think, and I'm really pleased that so many startups are delving into this potential market, I guess, because I think our ability to self-manage our health is and prevention is key to reducing the strain on the existing health system. And I think, we all know what it's like to get nudges, messages, buzzes, information about our health. Some people find it annoying, but I think a lot of people find it interesting to know my whole family do it, not because they're all tech heads,
Yeah.
because we just got used to us all saying, how's your BMI doing, or what. We have connected scales and things around the house. Maybe it's something to do with me. I don't know, but uh, so I think I'm really excited about where that can go. And I think what's fascinating is if you think about wearables and where they could extend to. You talked about ambient technology, but if you think about, I was having a conversation the other day with someone about computer vision, the ability to use visual technology to now clinically proven to be able to see whether someone has depression or see if they're likely to have a stroke. By facial, it's not so much facial recognition, it's recognizing signs that indicate some ensuing situation happening. And people start to get a bit big brothery about that. Don't point these cameras at me, and it's all about security and you know CIA and NSI and things like that. But those fears aside, that's a really exciting area of research and innovation. And so I was talking to someone who was saying, who else is really interested in this idea of not just the hospital bed as a wearable, because the hospital bed is where actually you've got most wearables on you, probably related to health, you're monitored up and all that sort of thing. But the car as a wearable, because you think how much time people spend in cars, and there's already devices in there that check for collisions and likelihood of lane changing, problems and approaching pedestrians and things like that. There's more and more sensors in cars that are sensing the driver. Are you going to fall asleep? Are you going to
Yeah.
potentially? So the potential of other care, what we wouldn't even consider care settings, such as vehicles, such as beds at home, maybe, I don't know, God forbid, but areas where the traditional view of a wearable being something strapped to your hand or your shoulder might also become a thing of the past, because we can choose to be an environment where we are being, I hate to use the word being monitored, but able to monitor ourselves and therefore influence our own health choices. Because at the end of the day, I think, personally for me, talk about me, I'm a 54-year-old male, right in the zone of where things like you start to think about, lifestyle diseases, what was my family history, what's my DNA say. But you start to think about a lot of that is down to the choices you make. And the choices you make in life are informed by the information around you. And more information that relates to your own personal health and well-being will inform
Yeah.
better choices. So I think that it's extremely exciting to think about in the prevention and detection end of um, the healthcare continuum, not just the monitoring where someone's, you already know they're well and they're maybe on recovery. What about preventing them even entering that cohort of sickness?
Yeah, yeah, and I'm totally with you on that. I'm also very interested in understanding better, my medical condition, my wellness, my health and wellness. I want to understand more to be able to lead a better life, and I think that comes with knowledge and education and the empowerment of patients, because at the end of the day we're all patients, we're all users of healthcare services, and we want to better understand our own data. As you said, I think early on in the talk, you said patients are mostly interested about their data and their condition, and that's still true today. It's just that we're a different generation of patients that are more demanding because we can see the possibilities. Um, as you said, the problem is not technology and data and digital capabilities. The problem is implementation and adoption, and according to what you have seen so far. And I would also add to that um, it also comes down to the personal preferences and demands of individual patients, but also doctors, because I think there's also doctors and nurses that are more technology savvy and they want to have more data to care for their patients.
Yeah.
Then again, you have others that could care less and would rather have nothing to do with technology. And by extension, that analogy is translated into big organizations. I think you can find organizations that are technology savvy and want more, and then you can find organizations that are happy with what they have and they could care less, right? So from individuals all the way to organizations, you see this different levels of maturity in technology.
Yeah.
um, but I guess the question that I'm driving towards is there are leaders, right? There's people that are behind these organizations, and what does it take for making those tough, difficult decisions in changing, and becoming more digitally mature?
It's really interesting what you said about the way different organizations see it. And there is a percentage of organizations that are probably just burying their head in the sand and saying, I can't keep up. I'm just going to get on with business as usual and hope this, bypasses me. There are a lot that are playing a waiting game, I think. The hospitals included, but, apart from what's mandated on them, they're thinking, well, maybe the hospital I'm partnered with down the road is already doing this. Perhaps I can piggyback on that. Or they're waiting to see what happens with whether this hype will blow over. And there are those that are taking the bull by the horns and saying we've got to get in front of this. And I think that choice is the one that healthcare leaders should be taking. There is no doubt in my mind that COVID has changed the world and we're not going back. We're not going to be on our phones all the time. We're going to be interacting like we are now, far more. And that's just one of the changes that is symptomatic of a shift in the world. And there's no doubt that the accelerating technology is going to unlock possibilities that we have to take advantage of, and we will take advantage of. To that, it's just the future is there, it's happening, and there's no point pretending it's not. So I think the things you need in place to, it's more about culture and leadership than it is about technology. I think yes, you need experts, you need resources in your organization that understand and can decipher the difference between edge cloud and hybrid cloud and federated data platforms and all the different protocols, etc. You need that. We can't all be experts in that area, but you need, first of all, you need vision. Like I say, you need it, and absolutely it has to be leader led. It cannot be, you can't expect an organization to transform at this pace in this way without someone saying this is our top priority or near the top priority for us to thrive, not just survive. So it needs to be leader. There needs to be an underlying strategy that's integrated. So there, as I said, there's going to be long-term foundational work that needs to be done that shouldn't interfere in the technology aspect with the fact that you need to change processes, that people need to be engaged, that you need to have successes and wins along the way. And it's not a silver bullet, it's a journey. So I always talk about it's multi-generational and multi-layered. The multi-generational aspect is we can let's not wait for the big bang, the revolution, to make some pretty important steps forward right now. And one of my colleagues and friends, a guy called Jim Shulin, that was the chief administration officer at Johns Hopkins, he coined a phrase. I don't know if it's his or not, but he coined a phrase that we all latched onto, which is think big, act small, and start now. So what he's basically saying is you think about the big vision, but you take some small steps and you do it right now. And that I think is so relevant to digital transformation because there's expertise needed, and of course you need things like agile governance, and you need to you don't want 15 initiatives going on at once that clash in with each other, and you need good programmatic skills and everything. But the point is that I don't believe any of this happens in one big bite. Um, so I think that idea of you can get started now, but you need to have a clear vision, a roadmap that is business led, not technology led. Most roadmaps for digital transformation say we'll install this, we'll release that, we'll put this live. It needs to be a business, even if you're a public organization like health. What's the outcomes and value we hope to unlock by doing these things,
Yeah.
and in what sequence? Because the business roadmap will then be served by the technology and data roadmap, not the other way around.
Yeah.
And we've seen that so many times in the NHS, technology, IT led programs that have fallen on their face because it's about, we're all going to do this, it's going to happen by then, and it takes way too long because you don't take people with you. And you underestimate the enormity of changing culture, behaviors, ways of working, people's minds along the way. And in my experience, the most effective way of doing that is contrary to what I normally say about the difference between transformation and incremental improvement, you can incrementally transform as long as your steps that you're taking are constantly building on the previous. Because, by the way, you learn from every step and you course correct, and you maybe go a little bit backwards to sideways to go forwards. That's the essence of agile. What's our next target condition? Not what's the North Star we have to get to now, and it's going to take us 20 years. What's our next target condition to move us towards that vision that we painted? So I think, yeah, I mean, it's a huge subject. Digital maturity for me is less about your HIMSS level and more about the cultural aspects of how it's led and how people are engaged in the process. Because I think it succeeds and fails based on that final yard or two of activation of the transformation itself.
That's great. And I like the idea of multi-layered, multi-generational, and also what you mentioned earlier, the value stream, and the idea that you need to build your business model with specific value outputs, right? And obviously those value outputs will differ depending on who is the receiver of that value, right? Who captures and who creates value. um, Even in the public sector, as you say, it is important to identify that.
Yeah, I mean, so often I smile about how we used to write our contracts for things like command center programs about when we would get paid for these different stages in the process, and we were based on when the analytic went live and when the customer signed off to say they accepted it. It was never on when value was realized. Now, of course, from the seller point of view, if we were held to when value was realized, we could be waiting 3 or 5 years to get paid. But actually, my recommendation would be, and it is now for all big programs like this, is and there's plenty of learning around this. Um, when you procure services, because obviously you do a lot of this transformational work in partnership, in ecosystems. No one provider can do everything, but the measures of success should be value based, and the measures of let's say payment fees should be linked to the unlocking of that value, not linked to I've installed and I've switched it on. Good luck. Hope you get on well with it.
Yes, I totally agree. But as you say, it's tough on the vendor, it's tough on the provider, and I guess there's a lot of negotiation that takes place there.
Yeah, well, it comes down to business models that should no longer be transactional. You pay me 50 million, I'll give you a command center, or you pay me 480 million, I'll give you a federated data platform. It should be uh, let's agree we're in a partnership that matures and develops over time, and we will be working together on these different stages in that multi-generational plan, not trying to quantify the trip to the moon and
Yeah.
saying, pay me now, and one day you'll get to the moon.
Yeah, and as you said, it shouldn't be transactional. It should be ongoing, right? Given exactly because you are drawing on data insights that could potentially lead to new services, improved services, and so on, right?
Precisely. And that's the essence of a learning healthcare organization, is that, we're doing this with the intent of unlocking value, but secondary and tertiary value is going to emerge. The analytic you develop to predict admissions to ED, that might also enable you to predict how you could avoid an admission. A great example was monitors that Philips are the world leaders in inpatient monitoring devices. Around 10% or so of the functionality that's built into that wonderful piece of kit is used by customers because maybe they don't need it, maybe they don't get trained up in it, whatever it might be. But there's a particular built-in algorithm that measures and quantifies patient deterioration, say in an ICU. If a patient is deteriorating and they're likely to be heading towards a situation where they crash or they need a specific intervention, flip that around, that same algorithm can tell you that patient's completely stable and could be stepped down from ICU to another part of the hospital. Now, to unlock that value, you have to think of that in a different way. You have to say, well, if I knew that and there's a bed available and I can act right now, I can release a very expensive place in ICU and keep flow moving. So it comes back to that sort of thinking of, who's how things can develop. And this is not blue sky thinking, by the way. This is not just searching around hoping we're going to find something. This is empathizing with the problems that a hospital really faces and saying, what if I knew a patient's stable, there's a bed available, and it's safe to make that decision, then I'd do it right away. Well, you can get that from your device, from your live bed state, from your written protocols, and it's here in your hand, that bit of information. In fact, it's alerted you. You don't have to be watching out for it. It's nudged you to make that decision. So those are for me, unlocking those simple opportunities is one of the many things we could be doing right now without regret.
Mark, thank you so much. I've taken more of your time than what you originally thought, but I hope it was valuable for you as well. I have certainly learned quite a lot from this discussion, and we touched on a number of different topics that probably we need to have more conversations on at some point.
Happy to come back.